Hi guys, good morning everyone. Welcome to the fourth episode of Dr. Tristan Anaesthesia Tutorials. I know it's Saturday. I'm sorry the episode's a bit late, but being a full-time clinician and being swept up in the torrent that this show and podcast and TikTok and everything has become has been it's been intense, and I hope you don't hold it against me that the episode is a day late in South Africa, but only a few hours late in other parts of the world, let's say. So guys, I told you that we were going to discuss remote site anesthesia today. It's a bit of a shorter topic, and I thought it was nice just for the end of the week. We've given you a lot so far. We've dealt with an introduction and history of anesthesia. We have spoken about considerations in pediatric anesthesia. And then we did a nearly 2-hour really great show, I think, on help I've been allocated to Peds Cath Lab and an approach to pediatric congenital heart disease. The responses have been overwhelming to those guys. We've had thousands of people watch the full episodes on YouTube. And then we've had literally millions of people watch the clips and the reels and things like that on TikTok and YouTube Shorts and all the other platforms. And the feedback has been amazing. It really is gratifying to know that my vision was correct, that there will be a need for this and that there will be a positive response. And it's overwhelmingly gratifying. I was saying to a friend of mine yesterday, I feel like I'm in the twilight zone because I love to teach. Sitting here talking to you guys about anesthesia and medicine and physiology and pharmacology and all of that stuff, it's like a nerd heaven for me. And the fact that now there are literally thousands, hundreds of thousands and millions of people that are enjoying this, watching this and getting some sort of a benefit or positive impact out of this is just, it's mind-blowing. And please keep watching this space. I've had a lot of feedback from you. All the information for now will be on my TikTok and my YouTube. My Apple Podcasts is still under construction. Spotify is live. Check my Twitter, my X feed, Instagram, Reels, etc. My website, I'm hoping it will be done and ready and live on Monday or Tuesday. And what'll be on there will be my bio, my CV, just to prove that I do actually know what I'm talking about, and a little bit about me, the number of cases I've done, what I've specialized in, etc. And then the episodes that have been released, all of it free to the public so far, will be on there, freely accessible, as well as my show notes, which will be a PDF of the slides, and then there will either be my notes that I've made or I will refer you to the resources that I used to make the episode. And then from the 1st of August, there's going to be even bigger changes coming to the channel, so please keep watching this space. And for parents, thank you so much for the feedback to that video that I did where I explain if your child is coming for an MRI, and then explaining what general anesthesia is. So I am going to be doing another one of those this weekend. We're going to be talking about fasting, okay? And this is for everyone. Why did anesthetists tell you not to eat? And what could happen if you do eat and you don't tell us? Okay, so keep an eye out for that. But as I said, today, guys, we're just going to do a pretty short presentation on non-operating room anesthesia. Okay, so this is the new fancier term for what used to be called remote site anesthesia. So this is what we're going to cover today. And this is, what is NORA? Where are the locations where NORA takes place? What are the requirements for NORA? What types of anesthesia can and should be done? What are the specific complications that are relevant to non-operating room anesthesia sites? And then I'm just going to briefly touch on specific procedures at the end of it, two of which I've already discussed on this channel, Cath Lab and the MRI, but we'll go through all of them again. So what is NORA? Well, as we say, non-operating room anesthesia is a relatively new classification for the spectrum of cases that occur outside of the typical, the traditional operating room suite. So we used to call it, as I said, remote site anesthesia. It's the kind of same thing. And maybe that term just sounded a little bit derogatory, like, oh, it's the remote site, you're in the basement or whatever. But so non-operating room anesthesia, I think, just makes it more formal and more impactful in terms of encouraging all of you, whether you are the intern involved on the surgical side, whether you are the radiographer, the radiologist, the anaesthetist, the nurse, etc., that this is anesthesia outside of the operating room. So everything that you would expect inside a theatre, the level of safety, the level of competence, the level of checking, all of that has to be exactly the same. This is an anesthetic, full safety requirements, but it's not in the operating room. So that's important. And if you look here, these are the procedures that can be done in the non-operating room arena. So most commonly, we're aware of radiological imaging, CTs, MRIs, PET scans. There's then interventional radiology. It could be vascular things such as TVARs and EVARs. There could be interventional neuroradiology, such as coiling or embolization of vascular tumors or aneurysms. Radiotherapy is done in a remote site, and for children, this is one of the most common anesthetics that they would get in a remote site. Cardiac cath lab, we've explained and been through that, and we'll go through it again. The EP lab, the electrophysiology lab, I did touch on that when we spoke about the cath lab. Other procedures in cardiology, we do sedation for transesophageal echocardiography and cardioversion. There are then gastroenterological procedures, endoscopy, stenting, injecting of bleeding ulcers, biopsying, ERCPs. There's then in psychiatry, ECT, electroconvulsive therapy, and there'll be an episode all on its own about that later on in the show, in the show's history. And then dentistry for children is a very common remote site or non-operating room anesthetic. So there's just some pictures that for you guys to see. You've got an MRI suite with a big red line saying do not bring metal past there. Here you've got a child under GA or sedation with a dentist and a assistant. This is radiation, okay? So this is a person being placed for narrow beam radiation. This one over here, I think, is a PET scan or may also be some sort of radiation. And then this is a cath lab or an endovascular an endovascular lab, sorry. So this is either the cardiac cath lab or it's the vascular lab where they do all of their endovascular procedures. So here we're going to run through just a summary again of procedures that can be done. So endoscopically, the issues is that you have an endoscope that may lead to upper airway obstruction. The patient is often in the prone or semi-prone position. In interventional radiology, it's mostly performed under general anesthesias, okay? However, some can be done under light to moderate sedation. Interventional cardiology in adults is almost always done just under local and sedation. And then obviously in children, I've explained to you what I do. Interventional pulmonology, that often requires intubation because that is for things like endobronchial ultrasound, transbronchial needle aspiration, airway stents. MRI, obviously the issue is the MRI compatible equipment and the magnetic field, which we'll speak about. And then IVF can be performed under blocks in the gynecologist's office. So why is non-operating room anesthesia challenging? Well, it's challenging because most of the time you have a very crowded room with limited access to the patient because there's an MRI machine in the way, there's a CT scan, there's a big table, there's a C-arm, there's a radiation beam, etc. Then these procedures don't just have a surgeon, a scrub sister, an assistant, and an anaesthetist. They have an anaesthetist, the anesthetic assistant, they've got the interventional radiologist or the gastroenterologist, etc. There's assistants, there's scrub sisters, there's radiology technicians, so the rooms are hell of a crowded. The lighting is suboptimal, especially if they're trying to look at screening images when they're for contrast or looking for a guide wire inside the patient. You can't have the lights bright. Power can be an issue because there's not a lot of plugs that are free because these machines draw so much power, and overloading of single plugs is something that I've seen in many non-operating room anesthetic areas. You're far away, okay, from everything. They put pharmacy in that first. I would say anesthetic help first, okay? You're not anywhere near where you can push the emergency button on the wall and you can then get a whole bunch of people to rush in and come and help you. In this instance, you're far away. I mean, at Charlotte Naqeke Hospital, the radiology suite is in the basement, the car park basement, literally. At Barra, the MRI suite is about 500 meters from the nearest anaesthetist, if not more. And the cath lab was even further. So things can go wrong, you're far away, okay? And the people often that are in the suite with you, besides your anesthetic nurse, are very, very good at what they do. But most procedures done in the non-operating room area are pretty standard and don't go pear-shaped. So when something goes wrong, I have had challenges like that where I was called to come and help with a patient who was unstable in the cardiac cath lab, an adult who was having an angioplasty and sedation, and for some or other reason, as they ballooned his coronary, the coronary artery ruptured. So essentially, he had a continuous cardiac tamponade. When I arrived, the patient was unstable, was bradycardic, and had a very, very low blood pressure. So I had to take over. We intubated, and I asked them what the problem was, and we saw on the screening and the ultrasound that he had a massive cardiac tamponade. So I told them to do aspiration, but I could see that it was arterial blood coming out of it, and everybody was frozen. The cardiologist didn't know what to do. So in that instance, I had to take charge because they were giving strange orders, like wanting to give atropine, wanting to give lignocaine. And so I just did in a, what some might call aggressive, but what I call firm way. I said, everybody stop, okay? You are the cardiologists. I am the anaesthetist. This patient is arresting and dying. We listen to me. Once we've got him back, if we get him back, we can listen to you about his coronary, okay? And I said, we need it to be fixed surgically, okay? So what happened? I then took over the resus. We did a full ACLS protocol, and I called the trauma surgeon, and they cracked open his chest in the cath lab. We attempted to correct, and unfortunately, he died. So he just exsanguinated, arrested, and we couldn't get him back because he had lost his whole left anterior descending coronary artery. So things can go pear-shaped is what I'm trying to say. If we then look at what some of the issues are in more detail, for the space, anesthesia is always an afterthought. So our machine doesn't have enough space, our piping and all of that, it's an issue. So how do you mitigate that? Well, you as the anaesthetist needs to be part of the plan from inception. So there is a beautiful, beautiful hospital in Johannesburg that is called the Joburg Surgical Hospital. And that was built with surgeons, anaesthetists, by doctors, investing in mind. So the space in all of their hybrid theatres for vascular and endovascular and cardiac procedures are incredible. We were thought of. Now, you'll find in a lot of smaller, older hospitals, we weren't thought of. So we're shoved off somewhere in the corner. So keep that in mind. There's often insufficient and outdated equipment in use. The non-operating room anesthesia suite is the red-headed stepchild. So no offense to anyone with red hair. And so we're an afterthought, and so we get shunted the old equipment. Proceduralists and their teams, so the surgeons, the endovascular guys, the radiologists, radiographers, etc., they're not familiar to working with anesthetic teams, so communication can be an issue. High-risk patients are served. We think that non-operating room anesthesia, so-called remote site, is only for well patients, but it's not. So you need to have pretty strict preoperative evaluation standards to determine who can be done safely in the non-operating room suite, and if they can't be done safely, what are you going to do about it? And more with every single day, the radiologists, the interventional gastros, the interventional neuroradiologists, the vascular surgeons, they are coming up with new, weird, and wonderful procedures. It's fantastic, good for them, but it means we have to be on the ball in terms of making sure we know exactly what they're going to be doing with each procedure. So what are the requirements for non-operative room anesthesia? Well, number one, you have to be familiar with the location and the resources. So in South Africa, if you work in private practice and you don't know the MRI suite at a hospital, you don't know the cath lab, I would strongly discourage taking a random emergency case there just because you're free for the day. You need to be familiar. You need to discuss, number two, procedure-specific requirements. So, for example, for an MRI, it doesn't matter what sedation they get, the child or the patient must just not move. Same for neurointervention. However, for endovascular procedures, for a TEVAR or an EVAR, for those of you that don't know those words, it is EVAR stands for endovascular aortic aneurysm repair, and a TEVAR is thoracic endovascular aortic aneurysm repair, whereby they put a stent and seal off the aneurysm. That requires a full GA. That requires lines, everything, because it could rupture and you could have to convert to open. And then the patients need to be selected and screened appropriately so that you know what you're dealing with in the non-operative room anesthesia suite. So what do you need, guys? That's non-negotiable. I know this is maybe a little bit difficult to see, but I'm going to read it out to you. You need an oxygen reliable source and full backup cylinders. So you need wall oxygen and backup cylinders. And if you don't have wall oxygen, you need large oxygen cylinders and backup. You need adequate suction. That is one of the biggest issues in remote site, because remember, guys, the central suction is in the theater complex most often, and so the further away you get, the wall suction gets weaker and weaker. So the solution to that is to have an electric suction backup as a mandatory in a non-operative remote site area, but you can't have that in the MRI suite. So just the other day, on Wednesday actually, I asked my team at the MRI suite to get maintenance to come and service the wall suction because it was very weak and we can't bring any other suction into the MRI suite. So in terms of anesthetic equipment, you need a BMV mask, you need an 80% positive pressure ventilation minimum, you need to have your drugs, you need to have an anesthetic machine that's functional, and your standard ASA monitoring. Okay, nothing different from what you would do. This is non-operating room anesthesia. It's anesthesia. Okay, you need enough electrical outlets and they have to be isolated, especially if there is a risk of water or blood on the floor, which there is in a lot of these procedures. You need adequate lighting, okay, and you need a backup light source like a torch or a headlamp or something. You need sufficient space for you, whoever is helping you, your anesthetic nurse and your machine and your trolley. You have to have full resuscitation equipment available, defib, emergency drugs, everything. And you have to have adequately trained staff. The building itself must be safe. which is a problem in some of our older buildings in South Africa. And you must have a proper PACU with a recovery area with adequately trained staff. So everything that I've said here is not different at all to what you would expect in a theatre. It's exactly the same. What monitoring do we do? Well, it all depends on the patient. So most commonly, okay, it will be ECG, blood pressure, oxygen saturation, capnography, and anesthetic agent volatile gas analysis, okay, if you're doing a GA. But you need, if the patient's intubated and ventilated with a subarachnoid hemorrhage on inotropes from ICU, neuro ICU, you need to transduce the A-line, the CVP, run the NORAD, etc., etc. So ECG, blood pressure can be the normal NIBP, but you must have facilities to transduce an A-line, pulse oximetry, capnometer, oxygen analyzer, anesthetic agent, a thermometer, and then all of your normal machine alarms. And these are very important because, as we said, you are far away from the patient, okay? And I'll show you, for example, in neurointervention, which I used to do a lot of at Barra, you've got the patient on the bed here that's floating freely, and you've got the rotating C-arm like this. When they do a DSA, which stands for digital subtraction angiography, we'll go through all of this in our neuro section on the channel, guys, so don't worry. Excuse me, I'm slipping off my chair. So what they do is this arm spins around and spins and spins and spins and spins like that to get it's an incredible image. I'll show you some videos of the entire cerebral vasculature, okay? Now, it's incredibly high-dose radiation, and so they don't do it often, but they need to see exactly where that aneurysm is to get the information. Now, my anesthetic machine is sitting somewhere on the side, and I've now got the C-arm going round and round like that. So my tubing in that patient has to be strapped to his chest all the way down to his abdomen and then come to my anesthetic machine so that the 1 meter area around the head of the patient like that is free. So you need long piping and oxygen and all of that. And the risk of those getting disconnected is very, very high. So guys, you know me, and I've got my important questions, okay? So for remote site or non-operating room anesthesia, these are the important questions. So number one, what exactly is being done here? Is it just a G-scope? Is it a diagnostic procedure, or are they intervening? Where and in what position will anesthesia be induced? Because sometimes they are needed lateral, sometimes they are needed prone. What position will the patient be in for the procedure again? So, will they be prone on their side? How far will their head be away from you, okay, from your machine? How will the patient be monitored? Standard ASA, or do they need invasive monitors? Is there a radiation hazard or magnet hazard, and is staff protected? Does the team know the risks and what constitutes an emergency? So for each specific procedure, do they know what could go wrong, and are they ready if it does go wrong? And then finally, is there a plan, and what is that plan in the event of an emergency? And is everyone's roles been defined? So I'm going to run through those questions again, guys, just as soon as I let my cat inside because he's scratching my door. So we're going to run through that again. And these are my important questions that have to be answered when you are in a non-operating room anesthetic suite, regardless of where you are, whether it's MRI, cath lab, or anything else for that matter. And the questions are, number one, what exactly is being done? Is it diagnostic or interventional? Number two, where and in what position will anesthesia be induced? So will it be induced outside, like for example, in the MRI suite maybe? Or will it be induced inside wherever you are? What position will the patient need to be in? for the procedure is the third question. And is it prone, lateral, supine? Where is their head in relation to you? Are you up here by the head? Or in some procedures, the head is down there and your anesthetic machine is at the foot of the bed. So you need to know that. Next, you need to know how will the patient be monitored. Obviously, standard ASA monitoring for everyone, but is there a need for invasive monitoring? Are they doing procedures whereby maybe ECG leads get in the way, like if they're working in cath lab on the chest? So you need to think about all of those things. Is there a radiation hazard, and is the staff protected? There should be full radiation protection with monitoring of how much radiation dosage people are getting. Does the team for this patient and this case know the risks and know what an emergency really is in this situation? If I say there's an emergency, will they react appropriately? And do I and the team have a plan in the event of an emergency? So those are the really important questions that you need to ask when you are presented with a NORA case. So what are the types of anesthesia that we can do in this instance? Okay, what we can do is sedation or general anesthesia. So this is the continuum from the American Society of Anesthesiologists of depth of sedation. So number one is minimal sedation, whereby the patient is normally responsive, their airway is unaffected, spontaneous ventilation is unaffected, and their CVS function is unaffected. This is if you give like an oral pre-med of Dormicum or some Ativan or something like that, or maybe you give like 1 or 2 milligrams of midazolam IV. Level 2 is moderate sedation. This is purposeful responses to verbal or gentle tactile stimulation. Airway, no intervention is required. Spontaneous ventilation is most often adequate, and the airway is usually maintained. So this is the most common level of sedation that would be applied for cath lab, for angiography, angioplasty, for gastroenterology, screening procedures, etc. So most screening procedures, most diagnostic procedures, and a couple of interventional radiology procedures or gastroenterology can be done under level 2 moderate sedation. Level 3 deep sedation is responsive only to purposeful the response is only purposeful to pain or to repeated stimulus. Airway intervention may be required. You may need to put in a Goodell airway or do a jaw thrust. Spontaneous ventilation may be inadequate here, and supplemental oxygen is often needed. Cardiovascular function is usually maintained though. So that deep level of sedation is done often for ERCPs, for endovascular ultrasound and biopsying, for TVARs and EVARs, for example. For general anesthesia, number 4, we all know the patient is unrousable to painful stimulus. Airway intervention is needed. Spontaneous ventilation is inadequate, and CVS function and blood pressure may be affected. So what is most important here, guys, is that we have correct patient selection. So there are specific conditions or patient states that require special care in non-operative room anesthesia. Number 1, if the patient is unable to cooperate and has severe intellectual disability, they won't understand sedation and instructions often, will need a GA. If they've got severe gastroesophageal reflux, they may be an aspiration risk. If they've got other medical conditions making them an aspiration risk. If they have orthopnea, so they can't lie flat, they get short of breath. If they've got severe raised ICP, you need to control their carbon dioxide. You can't sedate them if they've got a raised ICP and they build up CO2 and their intracranial pressure worsens. And we'll discuss all of that on Monday. If they're a known difficult airway, you need to be concerned. If they're doing some sort of dental, oral, craniofacial, or head and neck procedure, if they've got a respiratory tract infection, if they've got obstructive sleep apnea, if they are morbidly obese, if it's a long procedure with limited access to the airway, if it's an uncomfortable position, sedation often doesn't work, if they're going to be prone, and then if they have extremes of age. So these patients should have special care and should probably be done by a specialist with increased monitoring under general anesthesia. So what are the complications in non-operative room anesthesia? Well, there's a whole list there that I'm going to run through, but I want to say this, the most common issues is oversedation and loss of the airway. Okay, so the most common issue, I'll say it again, is loss of airway from oversedation. So we oversedate because the patient moved and the radiologist or the surgeon complained and we got a fright and we gave a little bit extra propofol or something, or Dormicum, and the patient stops breathing and they lose their airway and it's not recognized in time, or you can't rescue the airway. Those are the most common complications. However, all of them to list, obviously death, stridor, wheezing, coughing, aspiration, desaturation, anaphylaxis, apnea, cardiac arrest. Hypothermia is a big issue because remember, the cath lab and all of these huge machines at the MRI make a heck of amount of heat. So those rooms are air conditioned very cold. Laryngospasm, bronchospasm, airway obstruction, delirium, agitation, anesthetic awareness, IV line issues, unintended oversedation, hypotension, etc. So any complication that you can get from a general anesthetic, you can get from NORA and from sedation. And remember, the most common one, though, that is going to cause the most of your issues is oversedation and loss of the airway and not picking it up in time. So I'm just going to run through some specific procedures for the rest of this talk, and then we will call it a day for the week and the weekend. So number one, neurointervention. So neurointervention most commonly is the embolization of cerebral aneurysms and vascular malformations. Patients can have a reduced GCS and often have comorbidities. If you're having a ruptured cerebral aneurysm and a subarachnoid hemorrhage, you're often not a young, healthy person. The procedure is not painful, but immobilization is key. When they are doing that DSA that I described, where the patient is here and they inject contrast and then the C-arm rapidly rotates, the patient has to be completely solid like a rock, not moving for that, so that they get the right imaging. There is a possibility for catastrophic complications, that being that the aneurysm can rupture. And when we discuss neuroanesthesia, I'll explain to you we'll do a whole lecture on anesthesia for subarachnoid hemorrhage. You have to be vigilant and the communication has to be key, and these can be very, very long procedures. Cardiac cath lab, we've spoken about, one of my favorites. We're going to talk about it more next week. It is diagnostic to interventional procedures, as we said. Patients can range from being very well, a small ASD, VSD, or a little bit of angina coming for an angiogram, to critically ill, duct-dependent circulation in a tricuspid atresia, or a patient with a massive left ventricular infarct and LAD occlusion. The goal is to minimize the effects of whatever we give, sedation or general anesthesia, on the cardiovascular septum. Okay, so sedation is most commonly used for adults who are having any sort of cardiovascular issue. And then I explained to you about where we also will do a GA in children. And then, as we've said, repair of ASDs or VSDs require GA with intubation and transesophageal echocardiography. So pediatric non-operative room anesthesia is slightly unique because it requires more immobility, much deeper sedation because children cannot cooperate as adults, and general anesthesia is much more frequent than in adults. And remember, pediatric cardiology specifically requires general anesthesia and intimate knowledge of congenital cardiac disease. So what are the problems? Well, the neonatal problems, it's most often the airway, it's most often bleeding, congenital abnormalities, etc. Infants, difficult IV access, their nil per os is an issue, they get cold, and again, laryngospasm, bronchospasm, etc. Then as they get older, there's separation anxiety, PTSD, as well as airway issues and other. So pediatric NORA is a topic all on its own, and it's going to be discussed by me during our pediatric series on the channel. And then finally, the MRI suite, okay, where I work all the time. So what are the challenges? Well, you've got a 1 Tesla machine, sends out a magnetic field of 10,000 Gauss. Put that into context, the Earth's magnetic field is only 0.5. So the modern MRI machines, the 3 Tesla machines, have a magnetic field that is 15,000 times stronger than the Earth's magnetic field. So if you've ever been into an MRI suite, you'll see there's a metal detector at the door. And if you've gone in inadvertently with an earring, a nipple ring, and a pen in your pocket, a watch, a vape, whatever, you'll feel it pulling. And if you've ever put the laryngoscope down on the bed, it will get pulled into the machine. And this strong magnetic field can lead to absolutely catastrophic consequences if people are not aware of how strong that magnetic field is. So in the MRI suite, what are the most important things? The equipment must be MRI safe. So the patient must have no implants and the anesthetist must have no metal. Absolute immobility is needed for young children, especially, and then adults who are claustrophobic or who are mentally challenged. And auditory protection is necessary for everyone. I had an MRI, and I must say my sympathy for patients shot up exponentially. It's bloody loud, and it is incredibly claustrophobic and small in there. So I am sympathetic. So, and kids are not going to tolerate that. So obviously we're going to have to do some form of sedation or general anesthetic. So just quickly, we need to understand the labeling of equipment. So MR unsafe means that it should never enter the MRI scanner. MR conditional may safely enter the scanning room, but not within 1 meter of the scanner. And then MR safe is these have got no risk in the scanner and are completely safe. So here are the MRI disasters, guys. So if you look on this picture, that is a full bed, okay, sucked into a 3 Tesla MRI machine. So, and this is a shopping trolley sucked into a MRI machine. So these things have happened, okay, at Barra twice, as far as I was aware, while I was there in my time, and at other hospitals. One of them was a colleague of mine who was nearly killed because the nurse brought the stretcher close to the MRI machine, and even though the stretcher was MRI compatible, because we have one of those that detaches from the bed of the MRI machine, she brought the oxygen cylinder in. And my friend said all he saw and felt and heard was an oxygen cylinder swish, full oxygen cylinder swish past and almost brush his ear. As it hit the machine, it started to bend, okay? And they had to do what is called quenching of the machine. And that is where you push a big red button that is on the wall, and it floods the MRI machine with helium, which shuts it down immediately. However, it costs about 200,000 Rand to regas the helium and to get the MRI machine done working again. So it's a huge, huge, huge disaster. So The second one was a patient who died, who was on the bed, and the bed got sucked with the patient into the MRI suite. So it does happen. You have to have a protocol in place to prevent it from happening. Where I do MRIs now, we don't have a metal detector, but we have the room is completely separate with a second sliding door, separate from the MRI door, and no one crosses the first door without any of myself or my radiology colleagues, Kamo and them, and Mbali and Tumi that you met, without them checking that there's no metal. And then, like I said, if it's a 3 Tesla machine, the magnetic field is so strong that the machine should actually have a metal detector, like at the bank, that you walk through that beeps, or you can have a wand, which we do have, like you're a security guard at a Celine Dion concert, you know? But these can happen and can be absolutely catastrophic. So guys, in conclusion, non-operative room anesthesia requires the exact same standards as operating room anesthesia. Absolutely nothing whatsoever different. Complications during non-operative room anesthesia appear to be more common for a multitude of factors. Difficult procedures, unfamiliarity, remote location, all of those issues I told you about. And then it's the 4 P's, guys. Planning, preparation, protocols, and practice. Plan what you're going to do for each case in each non-operative room anesthetic suite. Prepare the day before and the morning of yourself, your registrar or colleagues, and the team so that you all know what is going to happen. Protocols, have them on the wall and be well versed. In the event of airway loss, X, Y, Z. In the event of ruptured subarachnoid hemorrhage, aneurysm, X, Y, Z. In the event that the TVAR fails, X, Y, Z. And then 4, practice as a team together and in simulation. So guys, I really hope you enjoyed that talk. I've had an incredible, mind-blowing, life-changing week with you all. The channel is only 10 days old today, and over 1,100 subscribers now, well over 2 million TikTok views. So please just keep liking, sharing, subscribing. My vision, guys, is to make this channel the home of online medical education and podcasting, and it's coming. Big things are happening. So I hope you enjoyed it. Please like, share, and subscribe. The link to everything is in the bio and in the comments. Have a lovely weekend, and watch out for me, because I will be putting out a little bit more short content over the course of the weekend. Stay blessed, guys. Thank you. And I really, really appreciate everything that you've done for me so far, guys.